Hi guys. So tonight we'll be talking about the physiology of pain, and looking specifically at the central nervous system and the peripheral nervous system in relation to that pain. So I'll talk a little bit about the past and current theories, describing pain and how we experience it, and looking at future directions, kind of where the literature is headed, and what those implications are to our clinical practice. So first, what is pain? So the International Association for the Study of Pain, or the IASP, defines it as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And this definition is pretty cool because it avoids tying pain to any particular stimulus. So it allows for that psychological and emotional component to be able to be factored in with that actual or potential tissue damage. And it's important to note that pain is not the same thing as nociception. So a lot of times in the literature or in discussions surrounding pain, those two are used interchangeably, and that's not quite accurate. Those are not the same things. So nociception, also defined by the IASP, is the neural process of encoding noxious stimuli. Now, while nociceptive activity is one of the strongest predictors of the experience of pain, again, is not the same thing as pain. So nociceptors are located in skin, muscle, joints, and viscera, and the quality of the pain sensation or pain experience is dependent on which tissue is being innervated and which nociceptor is being stimulated. The most commonly stimulated are going to be your the most commonly stimulated when we're talking about nociception are going to be those C nociceptors, and then the A delta fibers. So the C fibers are going to be your smaller diameter. They're more unmyelinated, so they travel slower and they create a burning or a dull pain sensation. The A delta fibers are going to be faster because they do have more myelination and they create more of a pricking pain sensation. There are studies that use electrical stimulation on muscle nerves, and those created more of an aching pain feeling. And then also they put them on visceral nerves, which created more of a fullness or a nausea feeling as well. So pain also can be activated through the central nociceptive pathway. So it doesn't always have to travel through that peripheral system, but it can be directly stimulated. It's also important to know that there are silent nociceptors, which are typically inactive or unresponsive under normal circumstances, but then they can be awakened by inflammation. So then they develop these spontaneous discharges, and then they can become more sensitive to that peripheral stimulation. And these are found in joint, cutaneous, and visceral nerves. So sensitization of these nociceptors is dependent on activation of the inflammatory mediators released in damaged tissue. So those inflammatory mediators are things like bradykinin, prostaglandin, serotonin, and histamine. And then mechanical, thermal, or chemical are the potential stimuli for that sensitization as well. There's a couple important terms to note. Hyperalgesia, which is an increase in the painfulness of a noxious stimulus and a reduction of the threshold for that pain. And that is broken down into primary and secondary. So primary hyperalgesia is where the enhanced pain is felt at the site of injury, whereas secondary hyperalgesia is where that enhanced pain is felt away from the original injury. So it's more of that referred pain. And then allodynia is a sensation of pain that's provoked in pathological circumstances by innocuous stimuli. So there are several different pain pathways. So here first are the ascending pain pathways in the anterolateral quadrant. Rexed classified these different laminae within the spinal cord. So it's laminae 1 through 10 based on their size, shape, and structure. And it's primarily laminae 1, 2, and 3 that play that crucial role in processing nociceptive information, because that's where the C and the A delta fibers that's where their input goes. So primarily talked about within the pain literature is the spinothalamic tract. So this tract is concentrated at laminae 1 and then 4 through AT630, and it mediates sensations of pain, cold, warmth, and touch. It responds the most to mechanical stimulation, especially of that noxious intensity. And then that input is then sent up to the thalamus. Next is the spinal mesencephalic tract and the spinal-reticular tracts. These are both also pretty frequently discussed within the pain literature, although the spinothalamic is still the main tract that's focused on. But the spinal mesencephalic tract, that one responds best to noxious stimulation. Oops. It responds to that noxious stimulation, and it then projects that information up to the midbrain, and it has more to do with aversive behavior, activating the descending analgesic system. It accesses midbrain locomotor center and plays a role in limiting nociception and in orienting. The spinal reticular tract travels along with that spinothalamic tract. However, then it goes off and projects to the brainstem, so it has more to do with signaling homeostatic changes and then triggering that motivational affective response. There's also the spinal limbic tract, and this is a multisynaptic pathway, and it carries that noxious input to the medial thalamus and then goes on to that limbic system. But we'll talk about the limbic system later this semester, so I'm not going to focus on that now. In the dorsal quadrant, there's the spino-cervicothalamic pathway, and it's primarily has to deal with tactile responses, although some animal studies do suggest that there's some response to noxious stimuli as well, but it's just a lot smaller of a reaction, and it's not as well known, and it hasn't been found in humans yet. But though that pathway projects up to the lateral thalamus. And then there's a postsynaptic dorsal column pathway, and that has to do with graphthesia, 2-point discrimination, and position sense. And this one doesn't have any role in cutaneous pain, but it does respond to both mechanical and chemical irritation of the viscera. So potentially might relay that visceral pain up and will go to the thalamus. So once it reaches the brain, if it is one of those tracts that goes up to the lateral thalamus, that responds most to that noxious mechanical stimuli, has to do with noxious heat and the C fiber volleys, and that plays a role in the sensory discriminative aspects of pain perception. From the lateral thalamus, it's then projected or sent on to the S1 cortex, which has to do with sensory discrimination, or to the S2 cortex, which has to do with memory processing through that limbic system. And then there's evidence of involvement with visceral and referred pain there as well. If it goes to the medial thalamus, that has more to do with the motivational affective responses to pain. It responds to noxious or cold stimuli, and it contributes to memory processing as well. Some of those inputs go directly to the cerebral cortex, so that would be going directly to that S1 cortex, S2 cortex, anterior insula, or the ACC. So those all have to do with ascending, so it's still going up to the brain. And then there's the descending analgesia system. So activation of this descending system will elicit analgesia by inhibiting that ascending nociceptive transmission through the spinal cord. So essentially, you're trying to inhibit it before it gets all the way up to the brain. And that's mediated by neurotransmitters like the opioids, serotonin, and catecholamines. There's a couple major descending systems. Primarily, or most frequently talked about in the literature, is the midbrain paraqueductal gray, or the PAG system. This inhibits those nociceptive dorsal horn neurons, so especially those spinothalamic tract cells that we talked about. Then there's the nucleus raphe magnus, or the NRM. Those also inhibit those spinothalamic tract cells. So it's said that PAG has an excitatory connection with the NRM. So essentially, the PAG is going to have those anti-nociceptive effects, and it's going to be stimulated, but then those effects are going to be mediated by the NRM. The dorsolateral pons has a few specific points that deal a lot with that stimulation as well, especially from electrical or chemical stimulation. The bulbar reticular formation does selectively excite noxious input, so that's a note there. And then the thalamus is known to help with that inhibition of the spinothalamic tract neurons, and it's potentially stimulated by the PAG or the NRM. So the PAG and the NRM are still going to be stimulated, and then they might also include that thalamus. And then the cerebral cortex, it is stimulated mechanically and inhibits the spinothalamic tract. However, it's just not as powerful as those PAG or NRM systems. So there's a couple different pain theories. Starting back in 1664 with Descartes, he had what's called the Cartesian viewpoint, and he was the very first person to have this concept of a mind-body dualism. And he was the first person as well to say that pain was actually felt in the brain, not at the site of injury. So he worked a lot more with phantom limb pain, and he also said that the soul of pain was located in the pineal gland. So after that, Melzack and Wall came out in 1965 with the gate control theory of pain, and we'll talk a little bit more about that. Then Wolf came out in 1983 talking about central sensitization. And this concept kind of creates a loop. So it's saying that pain is ascribed to sensitization, which then heightens hyperexcitability, which then intensifies the pain, and then goes back to that hyperexcitability. So it becomes this negative feedback loop, essentially. And it's a circular argument, but so far it's really only been demonstrated in laboratories, so it is primarily based on assumptions currently. Then in 1989, Melzack came up with the neuromatrix, and we'll talk more about that. And then 2003, Butler and Mosley released a book called Explain Pain, and this is an awesome book that explains chronic pain and then also pairs the brain with the pain experience. So a lot of really good information on this, so I wanted to include it here in the seminal works. So the gate control theory, developed in 1965, it involves a gate control system that modulates sensory input from the skin before it evokes pain perception and response. So essentially skin stimulation, so we're working at that peripheral level, creates nerve impulses that are transmitted to three spinal cord systems. And that's the substantial gelatinosa, which is in the dorsal horn of the spinal column or the spinal cord, the dorsal column fibers, which are then projected upwards towards the brain, and then the central transmission or T cells in the dorsal horn. So it's this idea that there's large and small diameter fibers, and they both come to the same point within the spinal cord, and they can't both be transmitted up at the same time. So one will inhibit the other one. Then there's the neuromatrix theory. This one, again, was developed in 1989 by Melzack. And this introduced the concept of the neurosignature. The interesting thing is this theory was not initially limited to just pain. It was designed to just play a role in all perceptual outputs. And it created this widespread neuronal network that produces the patterns of a sense of self. So it included somatosensory, limbic, and thalamocortical components. And as you can see in the figure here, that it has all of these different inputs that go into the neuromatrix, which then come out as pain perception, action programs, stress regulation programs, all of these things. But eventually that theory within the literature, other people came in and they started to kind of change it and develop it. And then it turned into the pain matrix. So the pain matrix involves a network of cortical areas that mediate that pain response. So nociceptive stimuli will elicit a pattern of brain responses reflecting a specific pain processing network. Excuse me. And so that's going to include things like the S1 and the S2 cortices, the insula, and the ACC. And it's used to encode pain intensity. There are a couple problems with this theory. For one, there's no true nociceptive specific neurons that are currently discovered. So essentially those neurons that fire due to pain, so there's a noxious stimuli, which then creates pain. But those stimuli, the parts of the brain or the neurons that are fired, it can also be activated by other non-nociceptive sensory input. There's also a poor correlation between the intensity of pain and then the magnitude of the response from the pain matrix. And then that pain matrix response also can be influenced by attentional context. So there's a couple different problems with looking at this just as a pain processing network. However, the concept of the matrix itself could be very useful. So now there's kind of a emerging idea or a new theory, and it involves the importance of salience. So saliency of a given sensory stimulus is its ability to stand out relative to the background. So this whole concept allows for swift and efficient adaptation of behavior to a changing environment. As humans, it's important for us to be able to recognize what stands out in order for survival. So nociceptive stimuli specifically has intrinsically a very high saliency content. We need to know when something could be painful. Whatever is causing that nociceptive stimuli could be dangerous to us, and so we have to be able to recognize that and adapt. And so saliency is actually considered one of the most important functions of nociception. So we could potentially take that matrix design or that matrix background and use it in detecting the salience of sensory stimuli instead. So the things like novelty and uncertainty are different factors that we know modulate saliency. And those factors are largely determined, or they might determine the response within that pain matrix. And then that matrix could also be used to detect other events that are significant to our bodily integrity, regardless of which sensory modality, if it's nociception or something else is involved. Some other future directions, some things that we're starting to see in the literature or starting to discuss, but are not as widely accepted across the practice as maybe they should be. Things like regional interdependence. So this is where a seemingly unrelated impairment in remote anatomical regions may contribute to the patient's primary symptoms. So this includes concepts like PERT or TMR that we started discussing this summer. And it includes musculoskeletal, neurophysiological, somatovisceral, and biopsychosocial responses. So we're looking beyond just the nervous system, we're looking at the person as a whole. Also would be the stability motor control. So this is looking at enhancing motor control and restoring functional stability around the joint. It involves things like the RNT or reactive neuromuscular training. A lot more research should be going into that because it would be awesome at knocking down some of that pain if we can restore that function and stability. And then another article that I had found that was really interesting called this concept, the Bayesian model, and it's perceiving pain consciousness from a probabilistic and inferential approach. So essentially, it's a mathematical equation taking into account current sensory information and past experiences in order to try and predict or see what the probability of what the pain output would be. So what does all of this mean for our clinical practice? So first looking at just our traditional intervention. So these are the things like biophysical agents, biofeedback, cryotherapy, heat, ultrasound, e-stim, foam rolling, ISDM, all of these things that are typically used day in and day out in the athletic training clinic. These things, a lot of them operate based on that gate control theory, especially the electrical or the thermal modalities, where you're just trying to block the ascending pain signals before they can go up and reach the brain. There's the diffuse noxious inhibitory control, or the DNIC, and this is all about using painful stimuli to inhibit pain at a different site. So these are the hurt so good treatments, things like foam rolling, or when people are just really aggressively using that ISTM. So that's those. And then there's also transient receptor proteins, which is used for the integumentary and fascial system. So that also has a bit to do with that myofascial treatment. And then finally, the placebo effect, which we typically say with things like ultrasound is going to achieve. So these are more so affecting a person's expectations. And all of these interventions are more geared towards short-term pain relief, either directly or indirectly, is how they operate. So directly is more modulating those inflammatory mediators that we talked about before, like the bradykinin and the prostaglandins. It's about slowing nerve conduction. It's about blocking pain signals and then stimulating that endogenous analgesia. Indirect mechanisms would be things like increasing blood flow, which will then support wound healing and decrease muscle spasm. There are some psychological interventions that we use fairly frequently. This is more engaging that mind-body connection. So looking at that greater matrix imagery is one that is super helpful because it's a way that you can activate the same brain areas as doing a movement, but without provoking that pain. There's a couple interesting studies on virtual reality meditation, a lot to do with mindfulness therapy, meditation, where you're trying to use deep breathing to stimulate that parasympathetic nervous system. Even things like pain education, just being able to communicate or educate the patient on what is happening in their body and reminding them that hurt does not always equal harm. You can be sore, but you can be safe. And even just helping the patient to understand those things so that they can acknowledge it can help them to reset the system and help to reduce any of those threats that are associated with pain. Physical activity is great. Motion is lotion, as according to Butler. But physical activity is great to improve sleep, facilitate weight loss, also to stimulate that endorphin secretion. So you're trying to stimulate that serotonin. Reverse deconditioning, super important, and then also to increase that production of the endogenous opioids as well. So they do have some of that, some of those neurological benefits for pain reduction. And of course, pharmacological agents. I really just focused on the non-opioids here. And the theory is that those sleeping nociceptors are then awakened when sensitized. So we should be able to reduce that pain by minimizing the sensation. Most commonly used are NSAIDs or those non-steroid anti-inflammatories, either topically or orally. And those are designed to block the synthesis of the prostaglandins, which then contribute to that nociceptor sensitization. And then also acetaminophen, which doesn't have that anti-inflammatory process, so it's theorized that it might not work as well as the anti-inflammatories, but it's worth noting. And then muscle relaxants as well. Some other potential strategies, kind of some preliminary results. Again, these are things that are maybe starting to be talked about, but not as commonly accepted within the broader nature of our profession just yet. And these are things like including body, mind, and soul all together. So one super interesting thing that we talked quite a bit about this summer is the neurophysiological approach. So it's using things like ISDM and cupping, but for a different purpose or a different reason than we thought that we were using them before. So before we talked a lot about how we're directly affecting or mechanically affecting the fascia. But now, what if instead we are stimulating that central nervous system, creating these efferent responses in order to cause relaxation and pain reduction to the local and surrounding tissues. So it just changes, it's even though it's the same intervention, it's changing our thoughts behind it and how we use it. So then acupuncture is another one that does have some evidence that it can activate the PAG or the RM descending analgesic pathways. And then also looking at biofield science. So this is that whole energy medicine component. And I think that it is severely underutilized within your typical athletic training room clinic. All right. If you guys have any questions, let me know on Monday when we discuss this more, or feel free to reach out to me as well. And here are my references. So thanks guys for listening and looking forward to seeing y'all in class. I gotta figure out how to turn the recording off. Okay, thanks guys.